Welcome to this continuing education program focusing on the Real Men Are Safe HIV and Sexual Risk Prevention Intervention targeting men in substance abuse treatment. My name is Donald Calsyn, and I was the lead investigator for the Real Men Are Safe clinical trial conducted by the National Institute on Drug Abuse's Clinical Trials Network. For today's program, I will start by providing a rationale for conducting a sexual risk reduction intervention in substance abuse treatment programs. Next, I will present the study design and procedures. I will follow with what the main outcome findings for the sexual risk reduction and for sex under the influence of drugs and alcohol. I plan to spend about half my time describing the intervention. I will finish with providing some ancillary findings that a substance abuse treatment professional could use in counseling sessions independent from the Real Men Are Safe intervention. Some people might argue that HIV prevention efforts are really not needed within a substance abuse treatment setting because there are already multiple outreach efforts being conducted by health departments. And when people get into treatment, they reduce their HIV transmission risk just by being in treatment. While it is true that injection risk behavior decreases tremendously with entry into substance abuse treatment, the same cannot be said of sexual risk behavior. There is some evidence of an overall decrease in the number of sex partners being associated with substance abuse treatment entry. However, there is little evidence that substance abuse treatment entry facilitates an increase in condom use. Furthermore, there is evidence from many studies that suggest men in substance abuse treatment engage in more sexual risk behavior than those in the general populations, especially in terms of number of partners. And I'll share that information, some of that data with you in a moment. I would also like to convince you that sex risk reduction intervention conducted in substance abuse treatment programs does not only promote HIV and sexually transmitted infection prevention, but also serves as an adjunct to relapse prevention efforts. More about that later. Most treatment programs provide a 1-hour HIV/AIDS prevention program that tend to be information-giving in nature. However, multiple meta-analysis research studies examining HIV prevention efforts in substance abuse programs have identified the most efficacious interventions span multiple sessions and utilize separate sessions for men and women. They also include condom demonstration skills, skill training exercises, peer group discussions, and utilize a variety of techniques in the intervention. The next 4 slides are based on data obtained for men and women between the ages of 18 and 44 who participated in the National Survey of Family Growth. This nationwide survey uses sophisticated sampling methods to survey a representative sample of American households. In this slide is presented the number of women sex partners for men who reported no use of illicit drugs in the past year, the red bars. Men who reported any marijuana use but no other illicit drug use, the blue bars, and men who reported any cocaine use, the green bars. On the horizontal axis are 4 partner categories for the past year: no partners, 1 partner, 2 partners, more than 2 partners. On the vertical axis is percent. As you can see, non-users in red are more likely to have no or 1 partner, and marijuana and cocaine users are more likely to have 2 or more than 2 partners in the past 12 months. In this slide is presented the number of men sex partners per women who reported no use of illicit drugs in the past year, again red bars, women who reported any marijuana use but no other illicit drug use, the blue bars, and women who reported any cocaine use, the green bars. Similar to men, non-users were more likely to have none or 1 partner, and marijuana and cocaine users are more likely to have 2 or more than 2 partners. The difference between users and non-users is more pronounced in the women. On this slide, I've graphed some sexually transmitted infection data from the National Survey on Family Growth. On the horizontal axis are 5 sexually transmitted infection categories: tested in the past year, treated in the past year, ever treated for herpes, ever treated for genital warts, ever treated for syphilis. Again, red bars are non-users, blue the marijuana-only users, and green the cocaine users. Users were more likely to have been tested or treated for an STI in the past year and more likely to have ever been treated for genital warts or syphilis. For herpes, non-users were only significantly less likely to have been treated than marijuana users. The pattern for women is similar, but again, there are more pronounced differences between users and non-users, and they're significantly different on each of the measures. In 2002, Richard Rawson and colleagues from UCLA published an article based on some survey work they had done with persons enrolled in substance abuse treatment programs. The survey asked questions related to a person's sexual experience they associated with their primary substance of abuse. In this slide are the percent answering yes to the item, "The use of my primary drug of abuse is so strongly associated with sex that I believe it will be difficult for me to separate my use of this substance from my sexual behavior." For men, cocaine and methamphetamine use are highly associated with sex and drugs being highly intertwined. For women, this feeling was not very high for any of the substance of abuse, with the exception of methamphetamine. Some substance abuse treatment providers might argue that sexual risk reduction is an important issue for substance abusers, but it's really not my job. However, when asked if focusing on relapse triggers was part of their job, substance abuse counselors uniformly respond, of course they are. We would argue that this data indicates that for many, sexual desires are a potential relapse trigger because sex and drugs are intertwined. In designing the Real Men Are Safe intervention, there is a strong emphasis on addressing the sexual behavior-drug use interaction. Let me close this section on the rationale for the study by summarizing our goals for this nationwide clinical trial. First, we wanted to develop an HIV sexual risk intervention for men in substance abuse treatment. A sexual risk reduction intervention had already been developed for women in substance abuse treatment, and the Clinical Trials Network was proceeding with a plan to assess the effectiveness of that intervention. We would then conduct the intervention protocols with men and women in tandem. In developing the intervention, we wanted to incorporate elements shown to be efficacious in previous studies and consistent with current theories on HIV risk reduction interventions. We wanted to compare the interventions we developed, the Real Men Are Safe, with the standard HIV prevention intervention typically provided in substance abuse treatment settings. Now, study designs and results. The study was conducted at 7 methadone maintenance and 7 psychosocial outpatient treatment programs across the country. As you can see from this map, they are predominantly in the East and the West. Sites in black lettering were methadone maintenance sites. Those in red were psychosocial outpatient sites. The 10 sites that are underlined conducted both the men's and the women's protocol. Here are the inclusion-exclusion criteria. Participants had to be men 18 years or older, in treatment at a participating program, self-report engaging in unprotected vaginal or anal intercourse in the past 6 months, agreeable to random assignment, and attending an HIV prevention intervention, and finally agreeable to the assessment schedule. Exclusion criteria were the mini mental status exam score of less than 25 or gross mental impairment as determined by local study clinician. We wanted to be very inclusive in terms of allowing almost anyone to be involved in the study. However, they had to at least be able to handle group material, and so these exclusion criteria are just to make sure they can handle being in a group. Finally, having a primary sexual partner or planning on getting pregnant was also exclusion criteria. The risk behavior survey, the mini mental status exam, and a brief demographic form were utilized to conduct the screening. The primary outcome for this study is the same as in many other HIV prevention studies: the number of unprotected vaginal and anal sexual occasions in the prior 90 days. Secondary outcomes focused on various condom-related measures, combining of sex and drugs, and the number of sexual partners. With the exception of attitudes towards condom use, these outcome variables were collected by the audio computer-assisted structured interview method, sometimes called audio CASI. A participant sits in front of a computer with headphones on. The interview questions appear on the screen and are spoken in the headphones. Responses are provided by keyboard or mouse. Prior research has demonstrated participants more readily endorse high-risk behaviors in a computer interview compared to a face-to-face, person-administered interview. Here is the design for the study. Clients were informed about the study by flyers posted in the clinic, announcements by clinical staff in treatment sessions, and open houses conducted by research staff. Interested clients completed a 20 to 30-minute screening assessment. Those eligible went on to complete a 2-hour baseline assessment. Upon completing the assessments, they were placed in a cohort waiting for randomization. Once there were enough men in the cohort to conduct a group, the whole cohort was randomized to attend either the 1-session HIV education intervention or the 5-session Real Men Are Safe. Follow-up assessments were conducted within 2 weeks of the end of the intervention and then at 3 and 6 month post-intervention. Today we will focus on the baseline 3 and 6 month follow-up assessments. This slide shows the equivalence between the two intervention conditions at baseline on demographics and the primary outcome measure of the number of unprotected sexual occasions in the past 90 days. Thus, our randomization was effective in ensuring our groups were similar before being exposed to the interventions. They did not differ significantly on any of these variables: age, race, ethnicity, monogamy status, methadone versus psychosocial outpatient treatment, education, and baseline level of our primary outcome, the number of unprotected sexual occasions. They also were not different on cocaine use in the past 30 days or heroin use in the past 30 days. Those variables are not shown. This slide shows the change in the number of unprotected sexual occasions for the intent to treat model, which includes all participants whether they attended the intervention or not. On the horizontal axis are the assessment time points. On the vertical axis is the model-based means for the number of unprotected sexual occasions. The Real Men Are Safe group reduces their number of unprotected sexual occasions more than the HIV Ed group during both the 3-month and the 6-month follow-up periods. The effect sizes are provided on the top of each bar. Although statistically significant, these are relatively small effect sizes. Not all participants attended the groups. I am sure that most of you are not surprised to find that some men in substance abuse treatment missed some or all of their groups. Many of these men live chaotic lives, and attending a voluntary research group may not be high in their priority list. We further analyzed the data to take into account whether participants actually attended the groups. This slide shows the change in the mean number of unprotected sexual occasions for men who attended the HIV education intervention and the men who attended 3 or more sessions of Real Men Are Safe. On the horizontal axis are again the assessment time points. On the vertical axis is the model-based means for the number of unprotected sexual occasions. The Real Men Are Safe group in orange reduces their risks more than the HIV Ed group in turquoise for those that completed the intervention. The effect sizes at 3 months is modest and a bit more robust at 6 months. Remember, this study was conducted in methadone maintenance clinics and psychosocial outpatient clinics. We further analyzed the data to take into account treatment modality. In the dark blue bars here are the methadone clients who attended the HIV education group. As we saw in the previous slide, for the whole group, there was no change in the number of unprotected sexual occasions across assessment time points. In the light blue turquoise bars are the methadone attendees at the Real Men Are Safe. A nice downward decrease in the number of unprotected sexual occasions is noted with modest effect size compared to the HIV Ed group. In the dark reddish or maroon bars are the psychosocial outpatient HIV Ed attendees. There is actually a slight non-significant increase in the number of unprotected sexual occasions across time. In the light reddish magenta bars are the psychosocial outpatient Real Men Are Safe attendees. The decrease in the number of unprotected sexual occasions is not only significantly different from the psychosocial outpatient attendees with more robust effect sizes, but the degree of change is significantly greater than the significant difference noted in the methadone participants. This slide is a further attempt by me to convince you that sex under the influence is a significant issue for substance abuse treatment attendees. On the left is the percent of participants at each assessment that endorsed any sex under the influence in the past 90 days. At baseline, 60% of the study participants endorsed engaging in sex under the influence in the past 90 days. At the 2 follow-up assessments, still over 30% endorsed a sex under the influence event in the past 90 days. On the right-hand side are the percent who endorsed being under the influence of drugs or alcohol at their most recent sexual occasion. Since the intervention specifically targets sex under the influence, we wanted to see if Real Men Are Safe attendants could have an effect on this behavior. Shown in this slide is a change over time in the percent of participants reporting sex under the influence at the most recent sexual event as a function of intervention condition. After controlling for baseline differences, fewer Real Men Are Safe participants reported sex under the influence at the most recent sexual event at the 3-month follow-up. However, at 6 months, the intervention groups are not significantly different. We were also interested in whether partner risk was associated with engaging in sex under the influence. Shown in this slide is the change in percent of participants reporting sex under the influence at the most recent sexual event as a function of partner risk. At each time point, sex under the influence is more likely to happen with a casual partner, the orange bars, than a regular partner, the green bars. You can see that overall the reduction in sex under the influence over time noted previously is driven by reduction in sex under the influence with casual partners. We're also interested in if there were treatment modality differences associated with sex under the influence. This slide shows the change in percent of participants reporting sex under the influence at the most recent sexual event as a function of treatment modality. At each time point, sex under the influence is more common among the methadone treatment participants, the brown bars, than the psychosocial outpatient treatment program participants, the turquoise bars. You can see the overall reduction in sex under the influence that happens over time happens in both treatment modalities. So what can we conclude from these findings? Real Men Are Safe was associated with greater sexual risk reduction among men in both methadone maintenance and psychosocial outpatient treatment compared to standard HIV education intervention. The effect remained strong at 6 months. Men in psychosocial outpatient treatment who completed the REMAS intervention reduced their number of unprotected sexual occasions more than men in methadone maintenance who completed the Real Men Are Safe intervention. Real Men Are Safe was associated with a reduction in sex under the influence of drugs or alcohol for men in treatment. There was a significant difference between the interventions at 3 months, but not at 6 months. Sex under the influence occurred more frequently with casual compared to regular partners, and with methadone maintenance patients compared to outpatient psychosocial program patients. I hope I have convinced you that the Real Men Are Safe intervention was effective in reducing sexual risk behavior and sex under the influence behavior, and might be worth a further evaluation. In the next portion of the program, I'm going to describe the Real Men Are Safe intervention in some detail and show how it is similar and different from a standard HIV education intervention that we provided. These interventions are being provided in group format to men in drug abuse treatment. All of the programs are co-led by male counselors employed at the program and trained by the lead node team. The same counselors run both groups. We wanted to demonstrate that substance abuse treatment counselors already working in a clinic could be trained to provide the intervention. The HIV education or control group is a 60-minute didactic presentation that was designed to mimic what most programs are already doing in terms of HIV prevention. As you can see here, we provide basic information about HIV/AIDS, its transmission, and prevention. There's a strong focus on condom use with condom application demonstrations and a focus on overcoming the common barriers to condom use. The techniques we used in the HIV education group are limited to lecture, information on flip charts, and condom application demonstrations. Much of the material for the Real Men Are Safe workshop comes from 3 programs listed here. The first 2, Time Out for Men and Approaches to HIV Education, were developed by Norma Bartholomew, Dwayne Simpson, and colleagues at the Institute for Behavior Research at Texas Christian University. This group has developed many fine interventions for use in substance abuse treatment programs. I highly recommend you visit their website for more information about their offerings. Project Light was a sexual risk reduction intervention directed at attendees to sexually transmitted infection clinics. Here are the 5 session topics for the Real Men Are Safe intervention. Most of the material comes from the intervention manuals for either Project Light or Time Out for Men. All of the material provided in the HIV Ed group was provided either in Session 1 or Session 2 of Real Men Are Safe. The 3rd session was designed specifically for this study because we could not find a good module that focused specifically on the issue of combining sex and drugs. The final 2 sessions focus on relationship and communication issues. The groups are 90 minutes and conducted by a pair of male counselors employed at the clinic who we trained. Listed here are the techniques utilized in the Real Men Are Safe groups. The techniques listed in black were also used in the HIV Ed group. Notice the items in black represent a teaching information giving participant passive mode, whereas those in green require more active participant participation. There is a greater focus on skill building and increasing motivation to change. Here's a summary for Session 1. The underlying modules are those also used in the HIV education intervention. The major difference in this session from what is done in HIV education groups is, first, more time is taken in the Getting Started module to build some group cohesion and explore what folks might want to accomplish in the group. Second, there is the introduction of a motivational task, the risk behavior exercise. Each of these statements is printed on a small card. In the risk behaviors exercise, each participant is handed a packet of these cards and 2 envelopes. One envelope is labeled Behaviors I have done in the past year. The other envelope is labeled Behaviors I have not done in the past year. Participants are instructed to place the cards in the envelope that are true for them. They are further told there will be no expectation to share their responses with the group unless they want to. They put these envelopes under their chair to be used later in the group. Next, they are given a second set of risk behavior cards. 3 boxes are placed in the middle of the room labeled high risk, medium risk, low risk. Participants are then asked to get up and put each card in the box they feel best describes the behavior in terms of transmitting HIV. The boxes are placed aside to be used later in the group. The next 3 modules are information giving focused. Information is displayed on newsprint size flip charts. Here is one of our flip charts. This one identifies infectious and non-infectious body fluids and risk behaviors associated with infectious fluids. We utilize flip charts for 2 reasons. One, it provides a visual as well as verbal stimuli to tap the different ways in which people learn. There's a lot of material to present, and many of the counselors we were training were unfamiliar with it. The flip charts provided reminder stimuli and helped them to keep on track without referring to the manual continuously. Here is one of the more important flip charts presenting a safe sex hierarchy, with abstinence being safest and anal sex without a condom being the most risky. In the HIV Ed, this is used to provide basic information. In the Real Men Are Safe, we also use this one to help folks identify their own risk in the past and what they would like it to be in the future with various partner options. Here, Mary Hatch-Millett and I are demonstrating correct condom application. I am putting a condom on one of our penis models. They come in various skin tones. With the top hand, I am ensuring air is out of the condom and that a reservoir space remains at the tip to catch ejaculate. The bottom hand is rolling the condom ring all the way to the base. Mary is inserting a female condom in the pelvic model. She's moving the inner ring so it covers the cervix and has the outer ring covering the lips of the vagina. Flip charts are displayed while the demonstration is going on that articulate the correct condom application and removal procedures. And you can see it's a step-by-step list here. Here's a similar list for the female condom. Again, these are being displayed while the demonstration is going on and then reviewed at the end of the demonstration. We finished Session 1 by returning to the risky behavior exercise. One counselor begins to go through the cards in the 3 boxes and asks the group if they concur with the card placement. The counselor purposely attempts to find a few cards that are likely to be viewed as out of place so as to generate discussion on why behaviors are or are not viewed as risky. Participants are now asked to look at the cards placed in their participated in the behavior envelope. Participants are reminded there is no requirement that they share what's in their envelope, but if they wish to, they can. Group members are asked if their perceptions of what constitutes risky sexual behavior has changed based on today's group. Finally, the group ends with a review of the safe sex hierarchy flip chart and a discussion of where one might draw lines for low, medium, and high risk. Session 2 attempts to build on Session 1 by first identifying healthy options with a harm reduction approach, recognizing that people may not be in treatment for the long haul. The Condom Barriers module is a brief information-giving presentation with the information provided on flip charts in the HIV education group. Whereas in the Real Men Are Safe group, this is a brainstorming exercise in which participants first generate a list of reasons why people do not use condoms. Next, the group generates a list of ways to overcome the barriers to condom use. The flip charts are displayed only after each brainstorming is finished to present any additional ideas generated by previous groups that the current group may have not thought of. Condom practice is an exercise where the participants get an opportunity to practice applying condoms to the models in a hand-on fashion. The final two Session 2 modules are exercises that will be very familiar with substance abuse treatment providers who have done relapse prevention groups. Instead of identifying triggers for drug-alcohol relapse, the focus is on identifying triggers for unsafe sex or sex under the influence. Problem-solving focuses on sex risk rather than drug or alcohol use. Most of the material for Session 3 is unique to the Real Men Are Safe intervention, with the primary focus being on the interplay between sex and drugs. Session 3 starts off with a motivational exercise in which participants are given 6 copies of the Safe Sex Hierarchy. At the top of each list is a type of potential sex partner: steady main sexual partner, new sexual partner, casual sexual partner who's not a drug user, casual sexual partner who is a drug user, a sexual partner providing sex in exchange for drugs, a prostitute. On each sexual hierarchy list, they are to circle the most risks they are willing to take with that type of partner. The point of the exercise is to get men to think about the choices they may need to make in the future and to ask for a commitment to the level of sex risk they want to maintain in the future. Next, we introduce a series of brainstorming exercises. In the first, we ask men to generate a list of ways in which being under the influence makes it easier to meet and obtain a sexual partner. Reasons are written on newsprint or whiteboard. They are asked to identify specific drugs for which the enhancements may be true. Next, we show this flip chart to see which ones they had already named and to see if any of those that they had not given but were on the flip charts were true for them too. Next, we ask them to identify ways in which sex under the influence improve the sexual experience itself. Again, responses are listed on newsprint or whiteboard. Next, we show this flip chart and again have a brief discussion. We then switch to focusing on impairments and ask them to generate a list of ways that drugs make it harder to meet and obtain a sexual partner. They generate their list, followed by showing the flip chart and discussion. This is followed by asking them ways in which sex under the influence impairs the sexual experience. We then show this flip chart, followed by discussion. Next, we ask them to look at the list they have generated and indicate if more recently their sex under the influence experiences have had more enhancements or more impairments associated with it. Usually, but not always, more impairments are noted versus enhancements. Next, we ask them to look at their 2 enhancement list and ask if there are ways to obtain those enhancements without being under the influence. We ask them to generate a list of ways to meet potential sexual partners without drugs or alcohol being involved. As before, a list is generated and written down on newsprint or whiteboard. This flip chart is then shown. Participants do not have difficulty generating this list, as it is very similar to a discussion they might have in a relapse prevention group. Next, we ask them to generate a list of ways to improve the sexual experience without drugs. Men often have a little more trouble generating this list. They are asked how non-substance abusers might spice up their sex lives. We finish the series of brainstorming exercises by showing this flip chart, followed by a discussion. We end Session 3 with a brief presentation and discussion of male sexual dysfunction. We emphasize how for most sexual dysfunctions, drug or alcohol use can cause or further contribute to the dysfunction. We also encourage men to seek help for any sexual dysfunction they continue to experience after discontinuing their substance use, emphasizing that most sexual dysfunction is treatable. Session 4 switches to a focus on relationships. Most of the material for these modules comes either from Time Out for Men or Project Light. In these modules, men are asked to share their views and experiences about relationships, and further asked to put themselves in the shoes of potential partners, and to get a sense of what their thoughts or feelings might be about relationships. Some people might call this empathy training, which is basically what we're trying to do here. There is a significant focus on taking responsibility for sexual risk in relationships and not leaving the issue of condom use up solely to their sexual partner. We end Session 4 with an introduction of a communication strategy for use in sexual relationships. Fortunately, it is a communication style that is likely to be very useful in many situations and settings. On this slide are the steps taught in using talk tools. It is basically an active listening and assertive communication style where there is an equal focus on listening and acknowledging what is important to your partner, and stating what is important to you. In Session 4, we conduct one scripted role play using these tools that focuses on resisting a sex and drugs temptation event. In Session 5, we practice the talk tools further using either scripted role plays or scenarios generated by the clients. A somewhat advanced communication technique is also introduced, turning around what they say. We then attempt to review the major areas covered in the workshop and summarize what was covered. As much as possible, we try to get the participants to identify the most important points covered in each session. We close with a graduation ceremony and handing out certificates of completion. Participants have a chance to debrief and indicate what was the most valuable to them. Okay, I now want to switch a little bit and finish by providing a few findings from the Real Men Are Safe protocol that a counselor might find useful in their counseling sessions, independent from whether the Real Men Are Safe intervention is conducted in their clinic. This slide shows for each assessment period the percent of men who reported that in the previous 90 days they had been tempted to use drugs or alcohol to enhance sex, the purple bars, or had been tempted to use drugs or alcohol to increase the likelihood that a sexual event would occur, the blue bars. We subsequently analyzed the data to determine if being tempted during the 190-day assessment period actually predicted sex under the influence during a following assessment period. Not surprisingly, it does. The point of this slide is that sexual and relationship needs and desires are potential relapse triggers, and it would be prudent to assess for them as potential triggers when conducting relapse treatment assessments. Now, when a client tells you that sex under the influence thoughts are a relapse trigger, you can share the findings covered on this slide. When asking participants to describe their most recent sexual event, we ask them to rate how sexually satisfying the event was on a 1 to 10 scale, with 1 being worst sex ever, 5 being pleasurable but nothing special, and 10 being the best sex ever. For 360 participants, we have their report of the most recent sexual event for baseline, 3-month, and 6 months. This allows us to compare sexual satisfaction ratings across 2 events as a function of whether the person was under the influence for the event. Some men were under the influence for both events, some were under the influence for neither event, and some were under the influence for one event and not the other. The red line shows sexual satisfaction ratings for the baseline and 3-month events for men who are under the influence for both events. The yellow line shows the same ratings for men who are not under the influence for either event. Notice these men rated sex as more satisfying at both assessment periods compared to those under the influence for both events. Now, one might argue that those not under the influence don't need drugs or alcohol to have a good sex, and so don't combine sex and drugs, whereas those under the influence need, I'll put that in quotes, drugs or alcohol to make sex pleasurable, and their ratings would be even lower if drugs had not been used. So let's now look at the men who reported both under the influence and not under the influence events. The green line represents those men who were under the influence for the most recent sexual event reported at baseline, but not under the influence for the event reported at 3 months. The blue line represents the men reporting not being under the influence for the baseline event, but were under the influence for the 6-month event. In each case, the not under the influence event is rated as more pleasurable than the under the influence event. The point being that you can tell your male clients there is a good evidence that sexual satisfaction is likely to be higher when engaging in sex not under the influence as compared to being under the influence. Here are the results for baseline and 6-month comparisons. The pattern is exactly the same. Not under the influence events are rated as more sexually satisfying than under the influence events. I'm not going to show you the slide for the 3 and 6-month comparisons, but the pattern remains the same. Substance abuse counselors are often expected to conduct a brief sexual risk assessment of their clients at treatment entry. We think there can be a temptation to cut that assessment short once the client tells you they are monogamous or are in a committed relationship. This slide shows some data that cautions against too brief an assessment and point to the need to conduct ongoing assessments. The 3 light and dark blue bars on the left side of the chart indicate the percent of men who report having only one sexual partner in the prior 90 days. The light blue section represents the percent for who that partner was a committed relationship, whereas the dark blue bars represent a partner who they identified as a casual partner. Thus, it's not only important to know how many partners they had, but who were these partners. The total percent of men having a single partner at each assessment period is fairly constant, just over 50% at each assessment time point. However, the orange-red bar on the right-hand side of the chart represents the percent of men reporting having the same single partner at each assessment, 28%. So whereas at any one time, over half the men will tell you they only had one partner in the last 90 days, only 28% of them had the same single monogamous partner for all 3 assessment periods. Men may only have one partner at a time, but who that partner is may change every few months. This slide shows the percent of men who reported multiple partners at each assessment, broken down by whether they had a committed relationship and casual partners, the dark blue sections, or just reported having casual partners, the light blue sections. At each assessment, over half the men who reported having multiple partners identified one of those partners as being a person with whom they were in a committed relationship. The point I want to make with this slide is that being in a committed relationship is not necessarily a good marker for low sexual risk. The next obvious question is, are these men using condoms with their committed relationship and casual partners? Condom use with a committed relationship partner was infrequent. This slide represents the percent of men who reported any condom use with a committed relationship partner, broken down by whether they only had a committed relationship partner, the light blue bars, or had both committed relationship and casual partners, the dark blue bars. The good news is that those who had casual partners were more likely to have used condoms at least some of the time with their committed relationship partner, compared to those who only had a committed relationship partner. The bad news is that in general, condom use by these men was low. This slide represents the percent of men who reported frequent condom use, greater than 50% of the time, with their casual partners, broken down by whether they only had casual partners, the light blue bars, or had both committed relationship and casual partners, the dark blue bars. At the 3-month assessment, more men who had only casual partners used condoms frequently with their casual partners compared to men who had both casual and committed relationship partners. Thus, men with both casual and committed relationship partners are using condoms less with their casual partners than men who only have casual partners. The point I want to drive home with these last 4 slides is that it is important to do a thorough sexual risk assessment and not assume monogamy or being in a committed relationship necessarily denotes low risk. And further, it is important to reassess folks frequently, as their risk status may be quite changeable. That brings us to the end of our continuing education program. It takes a lot of people to conduct one of these studies, a multiple site trial like the Real Men Are Safe study. So I'd like to, first of all, thank all of those people. It really does take a village. And I've listed just the numbers of people. I can't list each person, obviously, but the number of people involved in conducting this study. I do want to extend a special thanks to these key members of the Real Men Are Safe team. Co-lead investigator Susan Trost, who is the lead investigator for the women's protocol that was conducted by the Clinical Trials Network. And the 2 project managers, the initial project manager Sarah Burns and the second project manager Mary Hatch-Millett. These 2 individuals kept me sane during these trials as they do the bulk of the day-to-day project management. The lead statistician was Suzanne Doyle, and co-investigator Paul Christoph from the University of Pennsylvania, the Delaware Valley node, was very helpful in writing up much of the results. Funding for the Real Men Are Safe trial is provided by the NIDA Clinical Trials Network. The principal investigator for the Pacific Northwest node is Dennis Donovan. The Clinical Trials Network Research and Utilization Committee provided support in the development of this continuing education program and provided approval of its contents. Elizabeth Wells from the Clinical Trials Network Pacific Northwest Node was our representative to the Research Utilization Committee. The Addiction Technology Transfer Center's National Office is providing NIDA-approved CE credits for those who successfully complete the intervention. And finally, I want to give a special thanks to the Clinical Trials Network Dissemination Librarians, Meg Bruner and Nancy Sutherland, who along with our Internet Technology Specialist, Michael Lane, assisted in the preparation of this continuing education program. The CTN Dissemination Library is a great place to learn about the fine research and dissemination products being provided by the NIDA Clinical Trials Network. All the publications related to the Room Safe study, including the intervention manual itself, are obtainable from the